Hi everyone, welcome to Cultural Competency Training. We appreciate your time going through these modules and we hope they provide some insight on how to be more culturally competent when you provide healthcare. These modules were created by Michelle Nguyen, Macy Tralmer, Andrea Turner, Sally Yeung, and Dr. Amber Armstead in conjunction with Pi Theta Epsilon. Before taking any of the modules, please make sure that you have completed the Cultural Competency Pre-Survey. Each module will be available in video form on YouTube, and the PowerPoint file with the audio transcription will be available to you as well. The objectives of this module are to define culture, cultural identity, and intersectionality as it relates to healthcare, describe the principles of cultural competency and cultural humility, and their importance in healthcare, describe how bias, power, and privilege affect delivery of healthcare. The United States is a diverse country which people of unique cultures, heritages, and backgrounds call home. As future healthcare practitioners, it is inevitable that we will treat individuals whom we share few commonalities. While practitioners may try to treat all patients the same according to what is acceptable in their own culture, this well-intentioned method of interaction may not be perceived the same through the scope of diverse cultures. A significant percentage of individuals indicated that having a healthcare provider who shared or understood their culture was important to some degree. A significant number of individuals having a shared culture, or at least an understanding of culture, is important. However, many are not able to see a healthcare provider that met that preference. Individuals who identified as Black, Hispanic, or non-white were more likely to never see a healthcare provider who shared their culture, ethnicity, or background. As future healthcare providers, we are able to address this concern by increasing cultural competency and consequently build more meaningful relationships with our future patients. Increasing cultural competence in the healthcare setting may have a profound impact on overall wellness of individuals seeking care. Many minorities perceive receiving lower quality of care and report unease or shame during an interaction due to cultural miscommunication. This can result in decreased adherence to treatment plans, delay in seeking treatment, and strained patient-provider relationships. Building cultural competence can improve the quality of care practitioners provide by reducing bias, improving relationships, and empowering patients to take a more active role in their health. In this section, we will discuss what culture, cultural identity, and intersectionality are and how they can affect the delivery of healthcare. Culture can be defined as the shared ideas, meanings, and values acquired by individuals as members of society. Culture is learned from our environment rather than genetically gathered, and culture often influences us unconsciously. There are several ways in which culture affects healthcare. Specifically, culture influences individuals' perceptions and definitions of health and illness, preferences, language and cultural barriers, care process barriers, and stereotypes. All of these factors have an impact on health literacy and health outcomes. Cultural identity can be defined as an individual's identity as a member of a group with shared characteristics, which often, but not always, include racial, ethnic, or geographical origins. Cultural identity can affect health-related behaviors through perception of risk of disease, perceptions of cultural norms, desire to self-present as a member of a cultural group, functional meanings of behaviors, and cultural values. Through these pathways, cultural identity influences the likelihood that a person will engage in health protective behaviors, seek early detection of illness, and seek treatment for illness. Additionally, enabling factors within a society that can be supports or barriers to these behaviors include access to care, information, and resources. Intersectionality can be defined as a theoretical perspective which highlights the ways in which multiple systems of inequality work with and through one another at multiple levels of society. Intersectionality emphasizes the idea that groups with multiple disadvantaged statuses often, though not always, experience poorer health outcomes than groups with a single disadvantaged status. An example of a group who can be affected by intersectionality would be Black or African American women who experience marginalization based on race and gender. Another helpful image to understand intersectionality is that research shows that individuals with multiple disadvantaged statuses frequently perceive multiple forms of discrimination, as well as discrimination that are not reducible to a single axis of inequality. Thus, intersectionality can have an immense impact on healthcare interaction in cultural minority groups. In this section, we will discuss what cultural competence and cultural humility are and how they can affect the delivery of healthcare. In this section, we'll start by discussing cultural competence. The CDC defines cultural competence as a set of congruent behaviors, attitudes, and policies that come together in a system, agency, or among professionals that enables effective work in cross-cultural settings. Culture may include a person or group's language, thoughts, communications, actions, customs, beliefs, values, and institutions of racial, ethnic, religious, or social groups. Seeing as culture can impact every aspect of a person's life, it is important that we consider how these may impact the way we provide care as health professionals. Competence, on the other hand, is defined by the CDC as having the capacity to function effectively as an individual and an organization within the context of the cultural beliefs, behaviors, and needs presented. Gaining cultural competence is a developmental process that is continuously evolving. Each person or organization at any given point may have various levels of awareness, knowledge, and skills contributing to their cultural competence. In order for us to expand our competence, we must integrate our knowledge about cultural groups into our standards, policies, practices, and attitudes as healthcare professionals to improve the quality of services we are able to provide. This will allow us to improve the health and wellness outcomes in marginalized populations. Cultural humility, on the other hand, is defined as a lifelong process of self-reflection, self-critique, and reflexivity for an individual to learn not only about another culture, but to start examining their own beliefs and cultural identities. Reflexivity is the process of examining your own personal beliefs to be aware of biases and judgments. The phrase was first coined by Tervalon and Murray Garcia in 1998. Who first used cultural humility to educate physicians on how to work with culturally, ethnically, and racially diverse populations. Cultural humility plays an important role in our ability to build honest and trustworthy relationships with our patients, and it is vital for researchers in the process of understanding and eliminating health disparities. Cultural humility involves a critical consciousness that goes beyond self-awareness and cultural competence. It requires one to understand their own assumptions, biases, and values. When providing care, we must evaluate our own background and social environment and assess how it has shaped our personal experience. To truly achieve cultural humility, we must be aware and sensitive to the historical realities, such as oppression and violence, that many marginalized groups have faced. This history has contributed to an understandable skepticism of healthcare professionals and researchers in the eyes of these vulnerable populations. We must use cultural humility to build trust with members of diverse populations in order to address the history of mistrust and provide the highest quality of care. Both cultural competence and cultural humility play an essential role in healthcare. While many healthcare providers feel they have enough cultural knowledge to be competent in treating patients from diverse backgrounds, such as norms and customs, research actually indicates that this competence is lacking. One study showed that when assessing their cultural competence, few practitioners acknowledged the need to recognize racism, power imbalances, biases, or self-reflexivity in providing care. Another study concluded that nurses demonstrating culturally competent behaviors such as communication, trust building, and shared decision making were positively and significantly correlated with their patient satisfaction. Negative healthcare encounters are known to cause psychological and behavioral consequences for patients, particularly for those from minority or low socioeconomic populations. A negative encounter may cause a patient to become medically avoidant and worsen health behaviors, which could lead to adverse health outcomes. However, research indicates that cultural competence among healthcare providers has the ability to reduce negative encounters. One study found that when patients perceived their provider as more culturally competent, they experienced less shame and embarrassment resulting from their negative encounter, which then caused less medical avoidance among some of the patients. Cultural humility plays a very important role in healthcare. Increased humility among healthcare providers has been shown to correlate with improved patient health. Also, the providers demonstrating more cultural humility are able to more effectively communicate with their patients. This is beneficial in establishing trust and understanding between the patient and healthcare provider, which facilitates better health outcomes and follow-up visits for the patient. In this section, we will discuss what bias, power, and privilege are and how they can affect the delivery of healthcare. Bias is our tendency or desire to categorize individuals into groups in order to allow us to process information more quickly. These categorizations can be positive or negative and are not limited to racial biases, but they can extend to different diagnoses and other factors as well. There are two main types of bias: explicit and implicit. Explicit bias is what is generally conceptualized when thinking of the term bias, and describes conscious preferences or attitudes towards a particular group. In contrast, an implicit bias is a subconscious perception, stereotype, or feeling that has developed from past influences and can differ from an individual's conscious attitude. Individuals are often unaware of their implicit biases, as they are automatic thoughts that guide their decisions. Although implicit biases are more common and difficult to detect, both types of bias can contribute to how clinicians deliver healthcare, since both have potential to produce discriminatory behavior. In a healthcare setting, clinicians who have a high implicit bias towards their clients can cause them to deliver their services poorly. Examples include clinicians controlling the conversations with their patients, being less supportive, or spend less time around them. These negative experiences impact the attitudes patients will have towards receiving care, causing them to show less emotion, in addition to decreasing their overall trust towards their provider and treatment plans. Power can also have an effect on the delivery of healthcare. Power is both a social categorization and an unspoken presence of privilege that is held by the clinician. It is determined by marginalization and privilege, which can increase or decrease the power an individual holds. When working in a healthcare setting, clinicians should be conscious of behaviors that can surface when working with socially marginalized patients. Clinicians should note that authority and power favors themselves and can cause feelings of powerlessness from marginalized patients, which can decrease their experience when receiving care. To deliver a high quality of care, clinicians should be mindful of the internalized beliefs that are reinforced through power and privilege, and provide opportunities for their patients to have power during their treatments. Privilege is an unearned power that allows members of a dominant group to receive advantages as a result of the marginalization and oppression of those not part of the dominant group. Individuals who perceive themselves as having privilege report having higher levels of self-esteem, which improve their well-being. Privilege also directly affects the delivery of healthcare, as individuals who are privileged are more likely to be able to have tangible advantages, such as high-quality healthcare. In contrast, individuals who report having little to no privilege have lower levels of health and less access to health care. In this module, we have learned that culture, cultural identity, and intersectionality are influential patient factors in healthcare. Both cultural competence and cultural humility are long-term processes that allow us to provide better care to patients from diverse populations and establish trust and understanding. Cultural humility requires us to reflect and critically assess our own biases, and lastly, that bias, power, and privilege can have adverse effects on the delivery of healthcare. If you want to learn more about what was discussed in this module, please refer to these references. Thanks so much for listening, and we hope that this training is helpful for you.